So normal saline. Normal saline is one of the most used IV fluids in clinical settings. This is starting to change a little bit, which we'll get into later on in the video. But it's commonly assumed to be kind of this benign one-size-fits-all, just give them some fluids. But there's a lot more beneath the surface. There's things we have to be aware of, precautions, other fluids that we should think about. This is not a benign thing. We always tell our trainees, intravenous fluids, IVF, is a medication, and as such, we should think about it like a medication. We should think about indications, contraindications, complications, all that kind of stuff. So what is normal saline? Excuse us. Well, a normal saline is 0.9% sodium chloride solution. That's where we get kind of the 0.9%. And it is a crystalloid fluid. And if this isn't familiar to you, we actually put out a video. It's linked in that playlist, Intravenous Fluids, that looked at, we spelled wrong, crystalloid versus colloid. Crystalloid fluid is normal saline, lactated ringers, PlasmaLyte, all those. And normal saline, as we said, is a crystalloid fluid. It's composed of sodium and chloride, right? NaCl, salt, for all intents and purposes. And we call it normal, but interestingly enough, it is not really normal at all. It has about 154 milliequivalents of sodium and 154 milliequivalents of chloride. And in the blood, sodium, 135 to 145. Is normal, milliequivalents for sodium. So it has more sodium and more chloride than is physiologic, okay? So it is not necessarily normal as compared to the serum. It has higher concentrations of sodium and chloride than the blood does. In addition to that, the osmolarity of sodium chloride is about 308 milliosmoles per liter. And this is a little bit hypertonic, all right? So tonicity is the if you have a cell membrane, tonicity is the solute concentration on either side of the membrane that then causes water to flow from low solute to high solute. So hypertonic would be high solute, right? So water would flow towards hypertonic solutions across a cell membrane. And you can see the physiologic human osmolarity is about 285 to 295, whereas this quote-unquote normal saline is about 308. So it's not only supraphysiologic amounts of sodium, of chloride, but it's also hypertonic. And this is related to the supraphysiologic amounts of sodium and chloride, because what's the biggest things that lead to tonicity? Salt, sodium chloride. So the fact that there's higher concentrations in normal saline than in the plasma is what leads to it being hypertonic, hyperosmolar compared to the serum. So, look, we even put that in there. We forgot we put this little nice, normal saline is not truly normal. It contains more chloride and more sodium than the plasma, which we just talked about. So why is this important? Why is this relevant? Well, we're going to go over here to a little graphic. And this graphic is something that we covered, and it looks at fluid compartments. Okay? So fluid compartments in the body involve the intracellular space, the extracellular space. And within the extracellular space, outside of cells, there's the intravascular inside blood vessels and extravascular outside blood vessels, like the interstitial fluid. And these compartments are separated by cell membrane, right, for intracellular versus extracellular. And this is then driven by tonicity, right, because it has to cross a cell membrane. So normal saline, sodium chloride salt, as we said, is hypertonic. Okay, so it has tonicity. So if we're separating the extracellular fluid compartment from the intracellular fluid compartment by a cell membrane, that's what this purple line will be. And if this is confusing, check out that other video linked in the intravenous fluid video playlist in this video's description, because we go into it in detail. But if this is the cell membrane between intracellular space and extracellular space, sodium chloride does not readily cross this membrane because it is hypertonic. Okay, it has tonicity. So it does not, the fluid does not cross into the intracellular space. So it just stays in the extracellular space. But the intravascular and extravascular space are just separated by the blood vessel wall. And things can cross freely through there. So normal saline does cross freely between the intravascular and extravascular space. So if you were to have an IV in a vein and you were to give 1 liter of normal saline, this is a vein, this is capillary, right? And then this is going to be the artery, A for artery, V for vein. And you're giving fluid, and the blood travels from the arteries into the arterioles, into the capillaries, into the veins, into the venules, into the veins. So if you're giving fluid to the body, travels around to the arteries, you want to know how much is actually going to stay in the blood vessel, intravascular, versus going to the interstitium, right? All this space kind of outside the blood vessels, the interstitial space. And normal saline travels freely across here, so it's going to travel out into the interstitium freely, and it's going to equilibrate. And what we know is that within the extracellular space, 1/4 or 25% is intravascular, and 3/4 or 75% is extravascular. So this 1 liter of normal saline, only about 250 cc's will stay inside the blood vessels, and 750 cc's will travel into the extravascular space or the interstitium. All right, so just to give you some context about how much is staying in the blood vessels versus how much is going out. But as we said, none of that travels to the intracellular space, so it all stays extracellular, at least initially. All right, clinical uses of normal saline. What are some common indications? Well, the common indications tend to be similar to just common indications for fluid in general. Hypovolemia or shock. It depends on the shock state, right? So septic shock most often needs fluids. Hypovolemic shock most often needs fluids. Whereas other shock states, such as obstructive shock, things like pulmonary embolism, tamponade tension pneumothorax, usually need some fluids to a degree. But you can also get too much fluids. And then cardiogenic shock, which is when your heart is not working, does not need fluids. So hypovolemia and shock from things like sepsis or from hypovolemia or obstructive shock. Initial resuscitation with normal saline. Now, we personally are fans of lactated ringers. This is not meant to be medical advice. This is all opinion and education. We're fans of lactated ringers, LR, but you can use normal saline, and there's been lots of studies on this, and some studies seem to slightly benefit lactated ringers, especially for things like renal dysfunction, but then other studies show equivalency in some populations. So LR or normal saline, but hypovolemia, dehydration or ECX, that's extracellular fluid loss, lots of vomiting, diarrhea, burns, when you start to break, I guess is a word, the skin barrier. By burning the skin, you lose lots of fluids. Medication dilution, lots of meds are in normal saline, so it's compatible with a lot of IV meds. Hyponatremia. And this is an interesting one, right? So if you have low sodium in the body, normal saline does have, what do we say, 154 milliequivalents. Oop, that's a Q equivalents of sodium. So you can use normal saline to increase your sodium, but there's a lot more to this story, and it probably needs its own video. Sometimes you want normal saline, sometimes you might want 3% saline rather than 0.9%. Sometimes you don't want any of that. So a little more caveat here, but yeah, a solution to think about. And then operative fluids, again, maintenance, replacement. This is a world that we don't tend to live in, but it is a common thing that is discussed. Important reminder is normal saline does not provide calories, so it is not for nutrition at all. There is no caloric value to it. It also doesn't have a buffer. Some, which we'll talk about, like Lactated Ringers and PlasmaLyte, has a buffer solution. Normal saline does not have a buffer. And there's no other electrolytes other than sodium and chloride, right? There's no potassium, magnesium, calcium. It is just sodium and just chloride. All right, acid-base effects. This is a really important one with normal saline, and this is why some people favor other crystalloids, like Lactated Ringers or PlasmaLyte, like we've talked about, because normal saline, given it does not have a buffer, and given it has high concentrations of sodium and high concentrations of chloride, what can happen is you can get this hyperchloremic metabolic acidosis. Okay, so why it happens, normal saline contains more chloride than the plasma. Excess chloride reduces bicarbonate through this pathway in the kidneys, renal compensation. All right, and then this leads to a loss of bicarbonate and a non-anion get metabolic acidosis, right? So you get hyperchloremia, and that hyperchloremia leads to bicarbonate HCO3 bicarbonate losses, which then leads to a NAGMA, non-anion metabolic acidosis. All right, and normal saline in large volumes does lead to this. You will see it. So if someone has a NAGMA, think about what fluids they might have received, and this could be a possible culprit once you've ruled out other things. Right, so large volume resuscitation can cause acidosis. Some studies show increased risk of acute kidney injury and poor outcomes in the normal saline group as compared to what's referred to as balanced crystalloids. Right, and balanced crystalloids are things like lactated ringers and PlasmaLyte, which we'll be talking about in future videos. So be careful in patients who are acidotic, right? Normal saline, given the high amounts, 154 will be a broken record, but if you get pimped on this in the hospital, you'll know it. 154 milliequivalents of sodium and chloride can lead to this acidosis, so you gotta be really careful with that. Contraindications and caution. Using caution with those with hypernatremia. Again, 154 milliequivalents of sodium. This is higher than the normal serum concentration, so you got to be a little worried if someone is hypernatremic, giving them a bunch of sodium. Now, with that being said, when someone is hypernatremic, some mixed literature on this, again, another video, but you don't want to drop the sodium super quickly. So honestly, depending on what the sodium is, sometimes sodium chloride is an okay crystalloid for hypernatremia. It just depends on what you're trying to do. Hyperchloremia, definitely normal saline will aggravate that acid-base balance. Remember that non-anion metabolic acidosis, NAGMA, from hyperchloremia. Renal impairment, this is where they found in some studies that normal saline might be inferior, might be worse than lactated ringers, but it wasn't consistent across all studies. But in someone who has renal impairments, you just got to be careful. Again, that acidosis. Heart failure and cirrhosis, this is true of all crystalloid fluids. You don't want to give someone who is fluid overloaded fluid. Obviously, not all patients with a history of heart failure are fluid overloaded, depending on what's going on, but many of them are. So you just want to be careful in anybody who has risk of fluid overload. And then metabolic acidosis, we talked about, broken record here, NAGMA. Alternatives are lactated ringers and PlasmaLyte. We're going to be talking about each of these in future videos, so they'll be linked in that intravenous fluid playlist. So subscribe, hit the bell button, check out that playlist, and you'll be able to see those. Common myths about normal saline. Myth number one, normal saline, it's physiologic. Well, false, right? We talked about how the plasma chloride is 100 to 110 milliequivalents, and in normal saline, it's 154. Same thing with sodium, 154. So this is not a physiologic fluid. It is not a balanced, you'll hear that phrase, balanced crystalloid. It is not a balanced crystalloid. It has supraphysiologic amounts of sodium and chloride. Myth number two, it is safe for all patients. Context is everything. Overuse can lead to complications, or incorrect scenarios where you use it can lead to complications. So this is a medication, okay? And we should think about it like a medication. We shouldn't just be, quote unquote, willy-nilly throwing normal saline at everybody. Myth number three is balanced solutions are always better. We've been talking about lactated ringers and PlasmaLyte, all these balanced solutions, but that's not always better. Even if you are a subscriber to the literature that suggests balanced fluids are better in many situations, but normal saline is preferred in brain-injured patients because it does have that higher osmolarity, and in brain-injured patients, you don't want lower osmolarity, things that might contribute to cerebral edema. Hyponatremia, normal saline is often better, but this is still kind of caveated depending on what you're trying to do. And then some people in the operative setting enjoy it too, although we don't do surgery, so that's a little outside of our area of expertise. So if we were to summarize what we have learned thus far, normal saline is 0.9% sodium chloride. What is it? Sodium and chloride? 154 milliequivalents, 154 milliequivalents. All right, watch for acid, base, and electrolyte disturbances. Always assess clinical context. This is good for volume resuscitation, but long-term fluid therapy, especially with that risk of hyperchloremic metabolic acidosis, not always perfect. If we were to summarize it in chart form, as we've mentioned, this is 0.9% sodium chloride. We've talked about the milliequivalents of sodium and chloride. We talked about how it's hypertonic. We talked about the hyperchloremic metabolic acidosis it can cause. We talked about the indications and then the cautions as well. All right, lactated ringers. So, introduction, lactated ringers, LR, is a balanced isotonic crystalloid fluid. If you caught a normal saline video, balanced here is in comparison to unbalanced, things like normal saline or NS, because normal saline has supraphysiologic, higher than physiologic amounts of sodium and chloride, right? We talked about that. Whereas Lactated Ringers is more balanced. It's more similar to the serum. It's isotonic, meaning it does not exert tonicity on fluid across membranes. So if you were to put a cell membrane and you were to give LR, there would not be any crossing of fluid across that cell membrane. It's isotonic. The tonicity of the LR is similar to the intracellular tonicity. Again, we talked about tonicity in one of the previous videos, so definitely check that out. Commonly used in trauma, surgery, burns, obstetrics. At this point, it's commonly used really everywhere. We in both the intensive care unit and the emergency department tend to use Lactated Ringers as kind of our go-to first line. Again, this is not medical advice. This is all opinion and education, but yeah, tends to be our practice pattern. It closely mimics the plasma's electrolyte composition, and it does include a buffering agent, which we'll talk more about. And this close mimic is why they call it balanced. All right, what is Lactated Ringers? Well, Lactated Ringers is an IV fluid, intravenous fluid, containing multiple electrolytes and a buffer. The electrolytes it includes are sodium at 130 milliequivalents. This is in comparison to normal saline, which has 154 milliequivalents of sodium. And the body serum, right, the normal, quote unquote, is 135 to 145 milliequivalents of sodium. In Lactated Ringers, there's 109-ish milliequivalents of chloride. This is compared to normal saline, which is 154. And the body, the serum, which I think is like about 105. Potassium has 4-ish milliequivalents. You'll see anywhere from 3 to 4 of potassium in Lactated Ringers. Normal saline does not have any potassium. And serum potassium, normal is 3.5 to about 5.0-ish. It has calcium, 2.7 milliequivalents. None in normal saline. This is ionized calcium, and it's a little different measurement than we used to. So we'll have to let us know in the comments. We'll have to do some research. We can't recall this measurement, what the normal serum calcium is. And then it has lactate, which is interesting, 28. They have milliequivalents per liter, but millimoles as well. The thing to note, though, and the thing we'll talk more about is sodium lactate is what this form of lactate is. This is in comparison to lactic acid. And why is this important? Well, many of us in healthcare order a lactate. And when we order a serum lactate and it's elevated, it sometimes indicates that there's something bad going on. But that lactate we're ordering is actually lactic acid. This is different than the lactate in Lactated Ringers, which is sodium lactate. And we'll talk more about that. All right, the osmolarity of Lactated Ringers is about 273 milliosmoles per liter, and this is serum is about 290. Oh no, about 290. Normal saline we think is like about 310. So what you can see here is normal saline unbalanced, right? Not that close to serum, whereas Lactated Ringers is fairly similar to the serum values. It is a balanced solution, and it's also isotonic. So when we say isotonic, what do we mean? If we go over here, this is part of a lecture we did on fluid compartments, again, linked in the video description. There are two different main fluid compartments. There's the intracellular space and the extracellular space, and this is obviously separated by a cell membrane. Okay, and when something is isotonic, it means its tonicity is similar in the intracellular space as compared to the extracellular space. And when it's similar, all right, you draw a cell membrane, you have, 20 solute molecules and 3 solute molecules. Water usually crosses the cell membrane from low solute to high solute, so that'd be H2O. When something is isotonic, it's the same tonicity on both sides, so there's no traveling of fluid across the cell membrane. So when we think about the intracellular compartment and the extracellular compartment, Lactated Ringers will not cross the cell membrane from the extracellular compartment to the intracellular compartment. It will just stay in the extracellular compartment. So if we were to go down here, and we were to say, you have your artery, arterial, capillary, venule, vein, and you give 1 liter of lactated ringers, right? And it's circling, and it gets to the capillaries. Well, what we know is that none is going to go to the intracellular space, but the extracellular space is composed of both intravascular and extravascular. And the extravascular space is like that interstitium between blood vessels. And that's actually 75% of the extracellular space is extravascular. Whereas 1/4 or 25% of the extracellular space is intravascular, inside the blood vessel. And lactated ringers will actually travel and equilibrate between the intravascular and extravascular space. It will never cross, well, at least not initially, into the intracellular space. So when you give 1 liter of lactated ringers, 25%, right, will stay, 1/4, 25% or 250 cc's will stay intravascular. And the other 750 cc's will travel out into the interstitium. So 750 cc's will travel extravascular. All right, just to give you some context about how much stays in the blood vessels. All right, key point, as we mentioned, is that lactated ringers is more physiologic than normal saline due to lower chloride and an added buffer, which we'll talk more about. So clinical uses, again, not medical advice, but we use LR for, that's pretty much our go-to fluid unless someone's got traumatic brain injury or there's sodium derangements or there's something else going on. But common indications, trauma resuscitation, surgery, burns, labor and delivery, acute pancreatitis, and really just people who need volume in general, shouldn't say all, but many would benefit from LR over normal saline, possibly. The background here is that there's been tons of big studies, SALT ED trial, SALT ICU, I think Classics maybe was the name of another one, but don't quote us on that. But there's been a bunch of big time trials looking at normal saline versus lactated ringers, and some have favored lactated ringers, some have not favored either. So there's kind of argument and disagreement in the literature on whether you should use lactated ringers or if it doesn't matter. We personally believe that lactated ringers is more physiologic, and as such, that's the one we tend to grab first. The other thing to note here, lactate is metabolized by the liver to bicarbonate. So we mentioned that there is sodium lactate in lactated ringers. Sodium lactate is a base, so it buffers, so it can grab hydrogen ions. And when it does grab hydrogen ions, it can be turned into lactic acid, but it buffers these hydrogen ions. In addition to that, the liver converts it into bicarbonate to buffer. So this is a buffering, a part of lactated ringers that buffers, and it can help with acidemia, as compared to something like normal saline, which does not have any buffering agent in it. They have studied lactated ringers, and they have studied whether it does increase lactic acid. And again, there's some mixed literature, but not to any large degree. If anything, just to a small degree, or not at all. All right, acid, base, and electrolytes, we'll probably keep talking about this, but LR has a lower chloride content. So this reduces the risk of hyperchloremic metabolic acidosis. So if anyone watched our normal saline lecture, we talked about how there's 154 milliequivalents of chloride in normal saline, and this can lead to a hyperchloremic metabolic acidosis, where increased amounts of chloride lead to the kidney excreting bicarbonate, which then leads to a non-anion gap metabolic acidosis, or NAGMA. LR doesn't have that problem, right? It has about 109 milliequivalents of chloride, which is fairly physiologic, so it does not have the same risk of hyperchloremic metabolic acidosis that normal saline does. As we mentioned, it has lactate, sodium lactate, which acts as a buffer, helps maintain the pH. It helps correct metabolic acidosis as such. And then there is this idea that if someone has liver dysfunction, you might have to use caution because lactate metabolism may be impaired. We don't know of any actual literature that suggests this is true. We use lactated ringers in patients with liver dysfunction. Again, not medical advice, just opinion. But this is something that people talk about, so we included it. Contraindications and cautions. So there's this idea, and we still hear people say this, that if someone has hyperkalemia, you should be cautious with lactated ringers because lactated ringers has potassium. We mentioned lactated ringers has, anywhere from kind of 3 to 4 milliequivalents of potassium. But they've done trials on this, and they've compared lactated ringers to normal saline. And since normal saline can cause this non-anion gap metabolic acidosis, they actually find that more often normal saline leads to higher potassium levels, and that LR is a reasonable and safe option for hyperkalemia. Our personal opinion is that it actually is a better option than normal saline, but that's not shared by everybody. Some people still suggest that giving LR in someone with hyperkalemia can lead to worsening potassium, but our personal opinion is that that is a myth. But nonetheless, we wanted to cover it. Again, people talk about severe liver disease leading to impaired lactate metabolism. We don't know of any strong literature on that either. Blood transfusions is something to think about because, as we mentioned, lactated ringers contains calcium, and as such, the citrate in blood products can interact with that calcium, so you just got to be careful they're not compatible with the same IV. And then they have found that in those with traumatic brain injury, normal saline is a better fluid option because lactated ringers, it's isotonic, but it has less tonicity than normal saline, which is why normal saline is a better option in that group. And as we mentioned, there is calcium in lactated ringers, so calcium incompatible medications can't run with lactated ringers. All right, 5 common myths. Lactated ringers worsens lactic acid. As we mentioned, false. Sodium lactate is what is in lactated ringers. It's converted to bicarbonate. Again, they have studied this. It probably doesn't raise it at all, at least as compared to normal saline. If it does, it's just a small amount. But that is myth number 1. Myth number 2, lactated ringers is unsafe with all medications. Not true. Just those calcium incompatible drugs. Those are the ones you got to think about. Myth number 3, the old adage used to be lactated ringers is only for surgery. That has totally kind of fallen out of favor, and now there's a couple exceptions to this, like we talked about TBI and sodium derangements, but lactated ringers tends to be a fair drug, fair fluid to use for almost everybody, so no longer only for surgery. So if we look at clinical pearls, LR is a more balanced solution than normal saline, less likely to cause that non-anion get metabolic acidosis, that NAGMA, all right? It's preferred in trauma, burns, OB setting, in our humble opinion is almost everyone, right, other than the TBI patients and sodium derangements. Avoid with blood products. Remember, blood products have citrate, which will interact with the calcium in lactated ringers. And monitor potassium and liver dysfunction. We don't personally believe in this, but that is something that people talk about. So if we were to look at this in chart form, lactated ringers, sodium content 130 milliequivalents compared to 154 in normal saline. Chloride content 109 milliequivalents compared to 154 in normal saline. Potassium about 3 to 4. No potassium in normal saline. Calcium 2.7, no calcium in normal saline. Lactate, although this is sodium lactate, not lactic acid, 28, and remember this can be millimoles. Osmolarity, 273, much closer to physiologic osmolarity. Normal saline is about 310. And then acid base, it does alkalize because of that sodium lactate, so it buffers acidosis, which is nice. All right, D5W, also known as dextrose and water. So introducing D5W. D5W is 5% dextrose in water. That's where you get the 5. There can be D10W. There can be D20W. This is always the percent of the dextrose in the water. D5W is a hypotonic IV solution, right? Tonicity, we've done a whole video on just tonicity. Check it out if you want more information. But when you have a cell membrane, the tonicity drives which direction the free water travels. If you are hypotonic, that means the tonicity outside of the cell is less than inside the cell. And water will go from hypotonic areas to hypertonic areas. Whereas if you are hypertonic, that means the tonicity outside the cell is more than inside the cell. So water will travel from inside the cell to the outside of the cell. So this is hypotonic. So this is D5W traveling into the cell, which we'll talk more about. This provides free water and a small amount of glucose, right? Dextrose, commonly used for hypoglycemia and treating hypernatremia. This is key here. This is not for volume resuscitation because barely any of it stays in the intravascular space, which we will talk more about. What is D5W? As we mentioned, D5W is a solution of dextrose, which is glucose, sugar, and sterile water. Okay? It contains 50 grams of glucose per liter of water, right? 5%. And this can be adjusted. It could be D10W, it could be D20W, as we mentioned. This does give you a little bit of caloric intake, really not much at all, though. I've never verified this fact, but I've heard people say it's less than a Snickers bar. So this is not a lot of calories, but it is a little bit of calories. It is initially isotonic. So you're saying, what? You already said it's hypotonic. Now you're saying it's isotonic? But that is because the glucose in it, when it first goes into the vein, that glucose in it makes it isotonic. But that dextrose is quickly metabolized when you have insulin circulating, and then the solution becomes hypotonic because what's left is literally sterile water, free water, H2O, high quality H2O. This provides free water for distribution across all body compartments. So let's talk about that, body compartments. So we've done a whole video on fluid compartments linked in that video, in that playlist. So check that out if you want a more tailored fluid compartments video. Here, we're just going to talk about a couple things quick. When we think about fluid compartments in the body, there's two main ones. There's the intracellular compartment inside of the cells, and this makes up the bulk of where fluid goes. 66% of fluid in the body is intracellular inside the cells. There's then the extracellular compartment, the area outside of the cells. And this represents about 33% of all fluid in the body. But within the extracellular space, there's both intravascular, okay, and this makes up about 25% of the 33%, and then there's extravascular outside of the blood vessels in that kind of interstitium, and this makes up 75% of that 33%. Now, if we do the math quick, that means the intravascular space is about 8% of the total fluid in the body, right? 25% of 33%, and that'll be important. So when we think about this, if we were to draw it out in a diagram, we were to draw kind of this rectangle, we would say, well, 66%, as we said, is intracellular. So you have to cross a cell membrane, right? This is the cell membrane to get there, whereas 33% is extracellular, outside the cells. Cellular. But within that extracellular space, 25% or 8% of the total is intravascular, and 75% is extravascular. Well, tonicity determines what crosses intracellular. So when we have crystalloid IV fluid, this is things like normal saline, lactated ringers. All these are isotonic. So their tonicity is the same as inside the cell. So they don't cross the cell membrane. They don't go into the intracellular space. They stay extracellular. And they do equate throughout the whole extracellular space, both intravascular and extravascular. So 1 liter of lactated ringers, 25% is going to be intravascular, right? We'll stay in the intravascular space, 250 cc's. Whereas the other 750 cc's, even though it went into the intravascular space through an IV, it will equilibrate over the whole extravascular space. So 750 cc's will end up extravascular. Okay, but none of that will go intracellular. All of it will stay extracellular because it has tonicity. But we just mentioned D5W is hypotonic after that glucose is metabolized. So what that means is, since it's hypotonic, it will actually cross. So you put it in the IV, right? You give a liter, a D5W into the IV, into the intravascular space. Well, that will equilibrate with both the extravascular space as well as the intracellular space, which means if you give 1 liter of D5W, only 8% of it, 80 cc's, will stay intravascular, right? Because it will equate throughout all spaces, including this huge intracellular space, which is why it distributes across all body compartments, and it is not a resuscitative fluid, right? Because none of it stays, very little of it stays in the intravascular space. So what are the clinical uses then? Well, hypernatremia, high sodium. This is great because you're literally giving free water to dilute out that sodium. Hypoglycemia, obviously D5W has 5% dextrose, so it can help with hypoglycemia or low sugars. Lots of medications have D5W in it. And then some people think about using it as a maintenance fluid because it does contain a little bit of glucose. We're not a huge fan of this because it is, at the end of the day, a bunch of free water, so it will lead to lower sodium. But some people do use it. Again, not medical advice, opinion, education. Not suitable for volume resuscitation. Why is that? Well, as we said, it distributes outside the intravascular space. So it goes extravascular and it goes intracellular, which means at the end of the day, if we just do the math, only about 8% stays intravascular, or 80 cc's from 1 liter. You also don't want to use it if there's intracranial hypertension because the hypotonicity of it can lead to worsening cerebral edema. All right, distribution. Dextrose is rapidly metabolized, and then this D5W becomes free water, becomes hypotonic. It distributes across the intracellular space, which we said is 66% or 2/3, and the extracellular space, 33% or 1/3. And then that will leave only about 8%, as we said, in the intravascular space. Of the extracellular component, 25% remains intravascular, 25 of the 33. Look at that. We are being repetitive, but we're doing it intentionally because this is a really important concept. Isotonic initially, 252 milliosmoles per liter. Body is about 290 milliosmoles per liter. But once that dextrose is metabolized, it becomes rapidly hypotonic. Contraindications and caution: avoid using in those with elevated ICP, right? Hypotonic, we said that means that the fluid travels into the cells. If you have cerebral edema, you don't want a bunch of fluid traveling inside the swollen intracranial cells. Uncontrolled diabetes, this will increase your serum glucose because it has 5% dextrose. Hypovolemia or shock, this does not stay inside the blood vessel. It's an ineffective intravascular volume expander. Monitor for hyperglycemia and electrolyte imbalances, particularly low sodium. Sometimes we're rounding and we're like, someone's sodium keeps going down, why? And then we notice that someone had started them on D5W and continued it. So something to be cautious of, hyperglycemia and hyponatremia. Common myths about D5W: that it is isotonic and safe for resuscitation. This is absolutely not true. Don't do it. Don't do it. It provides substantial nutrition. It does provide a little bit of calories, and we should have verified this. Someone let us know. But we have heard that it's less than a Snickers, less than the calories in a Snickers. Myth number 3, it's harmless water. No, it can cause low sodium. It can cause cerebral edema. These are all things you have to be really careful, especially in really sick patients. All right, clinical pearls. Use cautiously in patients at risk for cerebral edema. Great for delivering free water or medications. Monitor glucose and sodium levels at all times. And consider other maintenance fluids for long-term use because it will slowly drop your sodium. If we look at a chart summarizing the properties, initially 252 milliosmoles per liter, but once that glucose is metabolized, it becomes rapidly hypotonic, low tonicity. As we just said, calorie content about 170 kilocalories per liter, but this is very low. This is not enough to nourish someone, although it does provide some calories, right? Albumin doesn't provide calories. Normal saline, well, it doesn't provide nutrition. Lactated Ringers, PlasmaLyte, no nutrition. So it does provide a little nutrition. Main use: free water for things like hypernatremia, and then glucose for hypoglycemia. Avoid use, we've talked about that a whole bunch. Distribution, it mostly goes intracellular, only 8% stays in the intravascular space, and it is a very poor intravascular volume expander for that reason. PlasmaLyte. So what we're going to be talking about today is we'll talk about what PlasmaLyte is, we'll talk about the clinical uses for PlasmaLyte, acid base and electrolyte effects, contraindications and cautions, common myths, and clinical pearls. As a caveat, we actually do not use PlasmaLyte in our day-to-day practice. So this is spoken based on our own kind of reading and understanding and knowledge behind it. And as always, as you know, this is not medical advice, just opinion and education. So if anyone does use PlasmaLyte in their day-to-day, definitely let us know. Let us know what you think when you use it, what you choose to use it for. We'd love for that real-world example to be shared. But PlasmaLyte in general is a balanced isotonic crystalloid solution. If we break that down, balanced, for those of you that have watched some of these videos, supports that this is kind of more physiologic. This is in contrast to an unbalanced crystalloid solution, such as normal saline, right? Normal saline has 154 milliequivalents of sodium. It's got 154 milliequivalents of chloride. This is much higher than serum levels, so this is an unbalanced solution. Whereas PlasmaLyte is much closer to serum physiologic levels of electrolytes, so it's balanced. It's isotonic, which means it does not exert tonicity, no tonicity. And tonicity, which we'll talk more about, is the amount of tone, the amount of solute on each side of a cell membrane that then draws water to one side of the cell membrane. So if something is isotonic, it is the same tonicity of the intracellular space, so it does not draw water across the cell membrane in either direction. It's neutral, it's isotonic. And then it is a crystalloid. This is in comparison to a colloid. We actually did a video on crystalloid versus colloids as well, so check that out, linked in that playlist. It is used for IV fluid resuscitation and maintenance, and it closely mimics human plasma in electrolyte composition and pH, right? So it's balanced, making it ideal for critical care settings. A little less common than the other balanced crystalloid, which is lactated ringers, although PlasmaLyte obviously is definitely out there. So definition, what is PlasmaLyte? Well, PlasmaLyte is a buffered isotonic crystalloid. Oh, that was a little wiggly, huh? Buffered isotonic crystalloid with acetate and gluconate that function as buffers. So lactated ringers has sodium lactate as its buffer. Normal saline does not have a buffer. And PlasmaLyte has acetate and gluconate as its buffer. So that helps if there's acidemia at play. It helps buffer that acidemia and improve pH. Its composition, as we mentioned, is much more balanced. It's much closer to the serum composition. If we were to look at normal saline, hopefully we could pull that out of our brain. Lactated ringers, hopefully we could pull that out of our brain. And then serum. PlasmaLyte has about 140 milliequivalents of sodium. Normal saline has 154. Lactated ringers has about 130-ish. And then serum is 135 to 145. So you can see PlasmaLyte sodium content is the same as serum, whereas normal saline is high. Lactated ringers is about the same, but just a little lower. Chloride in PlasmaLyte, 98 milliequivalents. Normal saline, 154 milliequivalents of chloride. Lactated ringers is like about 110, and serum is somewhere in this 110 range too. But the exact range, oh boy, someone quote us on this, like 90-ish, maybe 95 to 110, something like that. So this is about physiologic too. Normal saline higher. Lactated ringers is about physiologic as well. But these two, sodium and chloride and PlasmaLyte, are very balanced with the serum electrolytes. Potassium is 5 milliequivalents. Normal saline does not have potassium. LR is like about 3 to 4 milliequivalents of potassium. And then the serum potassium, 3 to 5.0. So the higher end, LR has a less potassium than PlasmaLyte, but still physiologic. Magnesium, 3 milliequivalents. Normal saline does not have magnesium. Lactated ringers does not have magnesium. And serum mag is like about 2 is normal for serum mag. And then you have these two buffers, acetate and gluconate, which buffer because they're turned into bicarbonate. And that is how they buffer the serum. The osmolarity is 294. Normal saline's osmolarity, I think, is like 310. LR, I think, is about maybe 290-ish. No, it's less than that. I think it's like 270-ish. And then serum is about 290. It's obviously a range, but that's right in that physiologic range. And then the pH is about 7.4, right? We know that normal serum pH is 7.35 to 7.45, so right smack dab in the middle. Normal saline, it varies based on the bag you get, but it's something like 7.25-ish, so acidemic compared to PlasmaLyte. So you can see here that this is very balanced. It's very physiologic. The electrolyte content, as well as the concentration, is much more similar to the serum than normal saline, and even more similar to the serum than lactated ringers, although it's certainly close. All right. As we mentioned, looks like we wrote it here to emphasize the point more, most physiologically similar crystalloid to the plasma, and that statement's in comparison to normal saline and even lactated ringers. All right, clinical uses of PlasmaLyte, common indications. Well, like all IV fluids, volume resuscitation is a big common indication. Maintenance fluids in hospitalized patients, rehydration and large volume ICU use. And all this is a little better because, again, it's so balanced. So with normal saline, you get worried about this hyperchloremic metabolic acidosis, because what happens is the 154 milliequivalents of chloride in normal saline leads to hyperchloremia, high chloride. That high chloride then causes the kidneys to excrete bicarbonate, and that leads to this non-anion gap metabolic acidosis, NAGMA, this hyperchloremic metabolic acidosis. PlasmaLyte has about 98 milliequivalents of chloride. This is about normal, right? This is just what's in the body. So you don't get that risk for hyperchloremic metabolic acidosis. LR, you don't get that risk either. This is a risk of using normal saline, so that's a big advantage over normal saline. It also has more stable acid-base profile. As we mentioned, PlasmaLyte has acetate buffer as well as gluconate buffer. So if the serum is acidemic, these buffers help improve the pH. LR has sodium lactate as a buffer. Normal saline does not have any buffer at all, right? So normal saline has no buffer. And that's why PlasmaLyte has a more stable acid-base profile. It does not cause hyperchloremic metabolic acidosis, and it does buffer with both acetate and gluconate to help improve the pH in those with acidemia. So good crystalloid in that sense. Acid base and electrolyte effects, we'll kind of go into this again. So PlasmaLyte has acetate and it has gluconate. And these both by the liver are converted to bicarbonate, right? Bicarbonate is HCO3 with a little negative on top. And this bicarbonate obviously helps buffer any acidosis, because acidosis is hydrogen ions. And those hydrogen ions can then be buffered by bicarbonate through the conversion of gluconate and acetate by the liver. Other things to note, the chloride level is similar to the plasma chloride level, prevents chloride overload, which is another way of saying that non-anion get metabolic acidosis, or that hyperchloremia that normal saline can cause. So you have this really nicely physiologic content of chloride in PlasmaLyte. Another thing to note is there's no calcium in PlasmaLyte. All right, this can be something we don't think about, but can be meaningful, right? So lactated ringers, which is also balanced, just like PlasmaLyte. But lactated ringers does have calcium in it, okay? And calcium with things like blood transfusions, right? Blood has citrate. And there's a whole slew of other medications like ceftriaxone, an antibiotic, that cannot be run with calcium. And if you only have one IV, or if you have a ton of different meds and things you need to give, this can actually be a big pain for nurses. If any nurses watching this, let us know how big of a pain that is when we order a bunch of lactated ringers that is incompatible with different medications because of the calcium content. So PlasmaLyte does not have calcium, so it's safe for blood transfusions and other kind of calcium intolerant drugs. There are small amounts of potassium, right, about 5 milliequivalents, as well as magnesium, about 3 milliequivalents. And this is probably a blessing. Again, this is fairly balanced, fairly physiologic. LR does have some potassium, right, about 3 to 4 milliequivalents. Normal saline does not have any potassium, LR does not have magnesium, and normal saline does not have magnesium. So you can see that PlasmaLyte kind of has this balanced amount of potassium and magnesium, similar to LR for potassium, but standalone, right? It's the LR and normal saline do not have any magnesium. So something to keep in mind when we think about uses. Contraindications and cautions. So one of the things people talk about is if you have hyperkalemia or high blood potassium, should you give PlasmaLyte? Because as we said, PlasmaLyte contains 5 milliequivalents of potassium. People talk about the same thing for lactated ringers, which has like 3 to 4 milliequivalents of potassium. And they have studied this in lactated ringers and found that LR is a better solution to give than normal saline, even for hyperkalemia, because it's so much more balanced. It doesn't cause that non-anion metabolic acidosis and things that can worsen some of your potassium levels. We don't know if there's similar data for PlasmaLyte, so it's unclear if this is a myth or not. but you probably should be a little cautious. 5 milliequivalents is a decent amount, although again, it's probably, not super meaningful, but maybe just choose lactated ringers, or if you believe lactated ringers has too much potassium too, normal saline, we suppose. But again, this is something that's taught, so it's important to know about. Renal failure, obviously, if you're giving a crystalloid that has potassium and magnesium and your kidneys are failing, so you're not able to regulate the amount of potassium and magnesium, that might be something to think about. If someone has an alkalosis, metabolic alkalosis, their pH is high, remember there's gluconate and acetate in PlasmaLyte, these buffers. So it can maybe worsen the pH because these are turned into bicarbonate. And then if you have liver dysfunction, the acetate metabolism into bicarbonate may be slow because the liver does that. So it might not have the same buffering capacity as it would if you had normal liver function. Common myths about PlasmaLyte. Myth number 1, it contains too much potassium. It contains 5 milliequivalents. This is generally safe, right? Normal potassium is 3.5 to 5 milliequivalents. This has 5 milliequivalents in a whole liter. So it's not a huge amount of potassium. If you have normal renal function, all that's probably safe and fine. Myth number 2, it's the same as LR. It is very different, right? Different buffering system. LR has sodium lactated as its buffer versus PlasmaLyte, which, as we said, has gluconate and acetate. In addition to that, PlasmaLyte has no calcium, whereas LR does have calcium, all right, about 2.5. And then PlasmaLyte has magnesium, right? It had about 3 milliequivalents per liter of magnesium, whereas Lactated Ringers does not have magnesium. Myth 3 is that it's too expensive. People suggest that the benefit here is it could reduce complications, ICU costs, and some long-term stuff. Again, we don't have PlasmaLyte to use at our institution, so we can't comment on this. It probably is more expensive than normal saline and Lactated Ringers, although we don't have those numbers, so just something to keep in mind. All right, clinical pearls. This is the closest match to plasma for fluid therapy. This is the most balanced, the most similar to the serum. Great for critically ill patients because it's so balanced. It is compatible with blood products because it does not have calcium. There's no calcium in it. When acid-base balance is a concern, especially when you're acidemic, because it has 2 buffering agents, gluconate and acetate. So all those are things to keep in mind with our friend here, PlasmaLyte. All right, here's a visual summary of PlasmaLyte. 140 milliequivalents of sodium, 98 of chloride, 5 of potassium, 3 of magnesium. You get 2 buffering solutions for the price of 1. The pH is very similar to normal serum pH. Osmolarity is very similar to normal serum pH. Acid-base effect, it does alkalize a little bit because you have those 2 buffers. It is used in a whole bunch of different places, and it is compatible with meds and blood products, whereas LR, given its calcium content, is not. All right, thanks for sticking around. So, albumin. Albumin is a colloid solution. This is in comparison to crystalloid. Okay, we've talked about the difference between crystalloid and colloid in a previous video. Crystalloids like normal saline, lactated ringers, PlasmaLyte, all those are crystalloids. This is a colloid. It's got protein in it. It is derived from human plasma, where they harvest the albumin protein, and it's used in volume resuscitation and specific kind of critical care scenarios, as well as other specific pathophysiologic scenarios that we'll talk more about. Unlike crystalloids, at least initially, it tends to stay in the intravascular space. We'll talk more about that. And that's because of its oncotic pressure, the oncotic pressure from the albumin itself, something we'll talk more about. All right, so what is albumin? Albumin is a plasma-derived protein, and it's used, some people call it this volume expander. And that's because it has that oncotic pressure, which we'll talk about in a little bit. The common formulations are both 5% albumin as well as 25% albumin. This is the percent of albumin in the fluid. So obviously 5% has less albumin in it than 25%. 5% albumin, some people use for volume resuscitation, although we'll talk about some of the literature on that. Whereas 25%, people tend to use this for things that, have quote-unquote oncotic support, where you have low albumin levels, low protein levels in the blood vessels, the intravascular space, and you're trying to buff up the plasma protein levels for kind of oncotic support to try to maintain a degree of intravascular volume. Okay, properties of albumin. It does remain in the intravascular space longer than crystalloid, all right, back to that oncotic pressure. And it provides oncotic pressure, but it also binds different substances, hormones, drugs. So it's a really important plasma protein. And when you're giving albumin through the IV, you have to remember that albumin does bind different hormones, all right? It does bind different drugs. It binds things like calcium as well. So this has a lot of different effects beyond just kind of that intravascular volume. But if we're going to go over and look and talk a little bit about intravascular volume. So there are three different, let's start with two different spaces, fluid compartments in the body. We've done a whole dedicated video on fluid compartments, so we'll kind of just do the abbreviated version here. But the two main ones are first the intracellular space, so the volume inside of the cells, and this is about 66% of all fluid in the body is inside the cells. Then you have the extracellular space. This is the area outside of the cells, and this is about 33% of fluid. Within that extracellular space, though, you have both intravascular inside the blood vessels, as well as extravascular outside the blood vessels, like in the interstitium. And within this 33%, the intravascular space makes up 25% of the extracellular space, whereas the extravascular space makes up 75% of the extracellular space. So if we were to draw this out in kind of diagram form, you would have about right here, this would be intracellular, okay? Right, and we said it's about 66%. And then you would have extracellular, would be this whole space. But when you divide that even further, you would have extravascular outside the blood vessels in the interstitium, and you'd have intravascular, okay? And as we mentioned, this would be about 25%. This would be about 75%. When we talk about, so albumin is a colloid, but we mentioned crystalloids. And crystalloids are things like normal saline, lactated ringers, PlasmaLyte. And crystalloids have tonicity, so they don't cross into the intracellular space, but they do equilibrate all throughout the extracellular space. So if you give 1 liter of normal saline, it will equilibrate, so about 250 cc's, 25% will stay in the blood vessels, and then 750 cc's or 75% will go out of the blood vessels into the interstitium. This is because there is no kind of oncotic pressure to keep that inside the blood vessels. It'll just travel through the blood vessel walls, through those endothelial cells, small pores out into the extravascular space. Whereas something like albumin, it has oncotic pressure. And oncotic pressure is that pressure that the proteins in the albumin exert to keep fluid inside of a space. So albumin tends to stay intravascular, does not tend to travel extravascular. So if you gave 1 liter of albumin, that whole 1 liter, that whole 1,000 cc's, at least initially would stay intravascular. Now, eventually the albumin breaks down and does go extravascular, but initially all 1,000 cc's would stay intravascular because of that oncotic pressure it is exerting. And this might seem like albumin would be a great choice. Let's use it all the time. But they've studied it, and in most scenarios, it doesn't seem to have improvements in clinically meaningful outcomes as compared to crystalloids. But that is a physiologic benefit of albumin, is that initially more of it stays intravascular. All right, so clinical uses, common indications. So it is a volume expander, right? We said most stays intravascular, especially if you have low blood albumin, low serum albumin, hypoalbuminemia. Some people use it in shock and sepsis, although as we said, when they've compared crystalloid to colloid versus colloid, they found no difference in outcomes, so colloid does not seem to be better than crystalloid, but people do use it. There are a couple indications where it does seem to have a benefit when they study it. Large volume paracentesis, so greater than 5 liters. A paracentesis is when someone has ascites, or fluid inside of their peritoneal cavity or inside their belly. And a paracentesis is where you stick a needle in there and you take that fluid out. People who have cirrhosis or liver failure sometimes get ascites. But if you do a large volume paracentesis, giving albumin back has been shown to improve outcomes, and probably won't dive into why, probably outside, the scope of this video. Hepatorenal syndrome, this is where you start to have renal dysfunction because your liver has failed. The albumin has been shown to improve renal function in that scenario. Burn patients, we don't take care of a lot of bad burn patients, but people do use albumin. And then nephrotic syndrome. This is a renal umbrella term for different renal diseases where you can lose albumin. The kidneys leak albumin into the urine and you pee it out, so you can get hypoalbuminemia, and sometimes you need albumin back. So these two are kind of more definitive evidence-based therapies. Volume expansion is, maybe some people do it, some don't. Then burn patients and nephrotic syndrome are, we don't know of trials necessarily that have proven that, but it is something that's more commonly done. Whereas these are very much evidence-based medicine, EBM. Not routinely used in trauma patients or as the initial fluid resuscitation, again, just because crystalloid has been proven to be just as good. All right, albumin versus crystalloid. Well, as we mentioned, albumin stays more intravascular because of, again, that oncotic pressure from the protein in albumin. So it's a better volume expansion per milliliter. As we said, you have 1 liter of normal saline or lactated ringers versus 1 liter of albumin. And how much stays intravascular? 100% stays intravascular, at least at first. Eventually it'll all leak out, which is probably why it doesn't have improved outcomes. Compared to 25% of lactated ringer stays intravascular. May reduce the total volume needed in shock resuscitation. There is some evidence here. No clear mortality benefit over crystalloids. As we mentioned, we comment on the SAFE trial here, but there's been a couple trials that have looked at that. And it is more expensive. Right, you have to derive it from human plasma. They literally take human plasma and they collect out the human albumin. So this is a human product. So obviously it's going to be more expensive, harder to come by compared to just a bag of normal saline or lactated ringers or PlasmaLyte. Right, contraindications and caution. Anytime someone has risk of fluid overload like heart failure, you have to be cautious giving any fluids, albumin included. Severe anemia, this is probably fair, but not a scenario that people probably come across. But it can hemodilute it out because it stays intravascular. And then hypersensitivity is one that does happen. This is human albumin, right, derived from humans, so you can get hypersensitivity to it. It has no nutritional value. It's not nutritional support, and it's not to be used routine in all shock or sepsis cases, because as we mentioned, the evidence-based medicine, the evidence does not suggest it's better than crystalloids like LRNS and PlasmaLyte. All right, cruising through here. Common myths about albumin. Myth number 1, it's always better than crystalloids. This is not evidence-based, right? Similar outcomes, as we've mentioned, in most resuscitation trials. So crystalloids first tends to be what people do. Again, not medical advice, just our opinion. Use 25% albumin for all volume expansion, right? We said 25% is the percent of albumin in the fluid. It's 25% versus 5%. Well, 5% is better for hypovolemia because they're getting more volume, right? Whereas 25%, they're getting more albumin, all right? So if you want to volume expand, 5%, because it has more volume in it. If you just want to try to get intravascular volume from the extravascular space, 25% more concentrated might be better. It is safe for all. There are side effects, as we mentioned. There's allergic reactions, there's volume overload. Again, this is a human-derived product, so it comes with all the challenges of that. So not totally benign. All right, last but not least, clinical pearls, 5% albumin for resuscitation, 25% for this quote-unquote oncotic support, which may or may not be a thing. Cirrhosis, hepatorenal syndrome, large volume paracentesis, all things to think about using albumin for. Monitor volume status closely, and consider cost and evidence base before routine use, right? This is not a routine use thing other than in some of these more evidence-based scenarios like large volume paracentesis and hepatorenal syndrome. That is a really bad arrow. It kind of looks like a tree. Maybe we'll just leave it as a tree. So if we were to compare 5% and 25%, 5% albumin, the concentration is 5 grams per 100 milliliters compared to 25%, which is 25 grams per 100 milliliters. So this is, what people talk about for volume resuscitation, whereas this is what people talk about for increasing albumin. Tonicity, isotonic, hyperoncotic. This is a little bit misleading because we're talking about oncotic and tonic. So hyperonconic, this will draw fluid from the extravascular space to the intravascular space. Whereas isotonic, right, fluid just kind of equilibrates with 5%. It does not draw as much, just a little bit. Volume expansion, oncotic support, sepsis and shock, cirrhosis, and hepatorenal syndrome. This is more evidence-based medicine. Duration in the plasma lasts about 16 to 24 hours before it all just will leak out as if it's a crystalloid. And then it's very expensive, which is another thing to note. Varies relative. There's certainly things that are more expensive, but it is not as cheap as a lot of the crystalloids.
Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.